are going to be Wan Nadia, Wan Muhammad Abdullah Yaqub, the CEO of Thompson Hospital, Kota Damansara, and the Group COO of TMC Life Services, or Life Sciences, sorry.
Are you able to edit?
Dr. Rosita Halinatun Hussain, the Deputy Director from the Unit for National Health Financing under the Planning and Development Division of the Ministry of Health. Tan Sri Dato Abu Bakar Sulaiman, the ex-chairman of IHH Healthcare and the former Director General of Health. And our moderator, Azrul Muhammad Khalib, founder and CEO of the Gallen Center for Health and Social Policy. Now, I'd like to invite all our panelists and our moderator to come up, take the stage, grab a microphone, get comfy, and once again, ladies and gentlemen, please give a warm welcome to this panel, Financing Private Healthcare. Financing Healthcare. I should have kept the private part to myself.
Thank you. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. I take it that the lack of enthusiasm is not because of the lack of interest in the topic. It's Saturday morning. I mean, seriously. You coming here all the way to yet again spend time to listen to a bunch of people talking about topics about you probably learn in class is probably not your ideal way to spend your Saturday. So I must praise you for being able to come here, and for you who have spent money to come here, well done. Now, the issue of money is very dear, especially when you're a student. You know how it is. Kais pagi makan pagi. And the thing is that very often in these hard times, when we talk about healthcare financing, it becomes more of an abstract topic that basically is something that policymakers speak about. It's more for other people to speak about. It's more for the politicians to talk about. Now, before we go into the topic, I just wanted to give a brief thanks to the organizers for organizing these series of panel discussions, which are very important and vital for the well-being of our country. When we talk about, when we first heard that these panels were being convened, I thought, especially with the topic, the theme, the bigger picture, I mean, what could be more important than the topics that we're listening to for the next 2 days? If we're talking about trying to make a better country, make a healthier people, these are exactly the topics that we want to be able to hear about. But most importantly, you as students, you as doctors, you as future politicians and policymakers should be able to influence what actually happens at the Ministry of Health. The minister said it very interestingly just now. We're not a communist country. We're a democracy, but we don't work everything from central command, and it should not be from central command. This is not the Soviet Union. But certainly, we're still missing the voices of people in influencing and participating in those policy discussions. So, well done for coming here. Most importantly, well done for organizing this today, MMI. So, we have with us quite a distinguished group of speakers. We'll do it this way. We'll be providing 7 minutes for your presentation. And I do hope that we can start off with the 7 minutes, and then we'll go into the different discussions so that we're able to elaborate, and we can refer to the slides that you present as we go along. So to kick off this morning's session on the difficult topic of ringgits and cents, we have with us, as mentioned, Tan Sri Dato Abu Bakar Sulaiman, who was the former Director General of Health, and he's the ex-chairman of IHH Healthcare. So you're basically, Tan Sri, part of the private sector now, right? After leaving the public sector. So you're in the best possible place to be able to provide a good comparison, but also insight into what are the problems, but most importantly, what can be done better. So, without further ado, Tan Sri, you have the floor. Ladies and gentlemen, give a warm applause to Tan Sri.
Assalamualaikum and good morning. Well, first organizers, thank you. Thank you for inviting me. And to all of you who have come this morning, well, congratulations. It's wonderful that you who are our future, the future of medicine in this country, should be interested in these type of issues which are critically important to us. Like I said, financing healthcare, but I put on there, developing an equitable and effective, sustainable healthcare system that promotes solidarity. So, as Rosita should be doing, okay, we should measure the indicators for equity, effectiveness, sustainability, as well as solidarity that should be measured continuously. Very important for us to do that. I'll come back to that maybe later because of time. Now, for all of you, what is the purpose of medicine? Do you know? If I were asked to you, what is the purpose? I wonder. Because advances in medicine has been amazing. But what have we seen? Medicine started as a caring profession. And what happened? Science dominates it. And then technology dominates it. And the individual who's suffering, then we put aside as we look after the systems in the body, the organ. Like I've been a kidney specialist, so I'm looking at the kidney, or the liver, or the heart, or the brain. How about the individual? And what happened now? Economics now dominate science, technology, and medicine. Tough, very tough. And technology and all these advances are double-edged sword. It comes with huge costs. And what happens now? Over 60% of healthcare costs in the world are spent on the last hour, on the last day, and the last week of life. And you can be emotional. You need to spend $1 million on this person to keep this person alive. There's $1 million that you cannot spend on hundreds of other people. And that is very tough. I don't want to go into the ethics of resource allocation, but that's very important. So because of all this, the Hastings Center in New York did an international consultation over 4 years in 14 countries. And they came up at an international conference with a report on the goals of medicine. Look carefully at these goals. Have they ever discussed any of this with you in medical school? It looks deceptively simple, but in fact, it is very complex. These goals should be the basis on how healthcare delivery should be organized. It should be how priorities for healthcare research should be done. And this should be the basis on how medical students should be taught. Now, if we want to organize a proper healthcare system, healthcare is all about social justice. We must be clear. What are the ethics? What is the morality behind what we want to do in healthcare? And Uwe Reinhardt, I met him 27 years ago, a wonderful individual. He passed away at the end of last year. This is what he said here. Be clear about what you want. Then organize your system to fit that. Different countries have different healthcare systems based on the economy, on the politics, the culture, the value system. I'll just give you some examples. In UK, in France, or in Canada. Of course, US is a free-for-all, the Wild Wild West. So each country will organize healthcare in what they think is the best system. And there is no single best system. You got to choose a system that suits your own context. Basically, there are these four models of healthcare. The Bismarck model started in Germany, 1883, and followed by other countries. These are insurance funds, which are private. Healthcare providers are private. Everybody must contribute to the healthcare fund. It started, I think, with about 8%. Now it is 15% of your payroll. The government, what do you call it? Government merely regulates the services to be provided. So the fund will negotiate with the doctors in the hospital what are the fees to be set. The Beveridge model is the UK model. Beveridge was the social activist that pushed this idea, and Bevan got through it in the government. So in this system, everything is free through taxation. The providers, most of them, are either public hospital or private GPs. Okay? So private doctors are involved here also. And the service cost decided and controlled by the government. And interestingly, you can see Cuba and US Department of Veterans Affairs use this model. And Cuba, you can look at the vital statistics, their achievement in health is very impressive. And then you have the national health insurance model, or the compulsory insurance model, which is, the classical ones are Korea and Taiwan. So here is a single fund, government fund, single payer system is the cheapest, most efficient in terms of administration. But the other models in Canada is a government fund at the province level with private provision. So it's very interesting here. Funds are public, provision is private. Now, out-of-pocket model, just like US actually got insurance and out-of-pocket model. So in Malaysia, it is government plus out-of-pocket. Generally, the out-of-pocket model are the countries that are less developed. Most of the developed countries have got a particular delivery system. And you look at how much out-of-pocket, Malaysia, I would consider this because it is rising. And Rista will tell you, it is now 38%. Well, OECD countries pay about that amount as well. But I think for us, that's quite a bit. But you can see, Britain is quite low. What are the considerations that we want to have a look at, in terms of healthcare delivery? We look at these four areas. One is coverage. When we talk about universal coverage, we cover everybody. Remember, we cover everybody. But universal coverage does not cover everything. Okay? Because what must be covered must be evidence-based, must be proven. If it's not proven, it is not covered. So the issue that we see with the out-pocket model in Malaysia, private sector, in the US, there's too much of over-servicing and over-utilization. Okay? But anyway, no time for me to discuss about management of supply and management of demand. No, there are tools to decide that. But new technology, important for us, the introduction has to be done in a proper way. And in UK and US, they do comparative effectiveness research to decide what are the new technology that can be introduced. Because, healthcare system around the world are fragmented, most of them, are too expensive, not integrated, and most of them are failures. Why do I say that? People go to hospital to get well, but instead, they can get sick, they can get worse, and many of them die as a result of the intervention. That's very tough. You know that if you got stage 4 cancer, more people die from the intervention than from the cancer. That's tough. But there are data that shows this. So the cost varying, but our challenges, how to reduce costs, to improve access, improve the experience of care, how to make it safer and more effective. That means you've got to measure the outcomes. These are the challenges facing us. This is a major challenge, as I've mentioned. How well are we doing in terms of patient safety? All countries have to measure this. Why do patients, why do you operate in the wrong patient? Why do you give medicine to the wrong patient? Why is it don't give the right patient medicine to the right patient? These are everyday problems in all countries. So, measurement of performance of service delivery must be done. You can ask Rosita later on, are we measuring or not? We are not. Choice. Okay, this is very important. Some countries allow you to choose which insurance you want. And they also allow you to choose which doctor or hospital you want. It varies. Malaysian health system funded by tax, nominal co-payment, but for private sector, private insurance, another pocket. The issue is this. The insurance that are not for profit, like France, Germany, Taiwan, India, and Japan, the fund is collected merely to pay. It does not deny treatment. But for private insurance, they will deny coverage and deny treatment. They must have everything. Now, this lady helped to develop a Taiwan system. She happened to be the wife. Okay, my last slide. She's happened to be the wife of Wei Rana. See what she said? No matter how good healthcare, people complain. No matter how much you put in money into the system, doctors and hospitals complain. No matter how hard you try to reform, you say it has failed. Thank you very much.
Thank you very much, Tan Sri. I think Tan Sri's presentation certainly gave us a very good teaser as to what to expect in regards to the discussion before this session, but most importantly allows us to set the stage and the concept in terms of what Malaysia has and most importantly what is present today, and the comparison that he provided with regards to different models is very important for us to follow the next presentation, which is, I would say, I would consider the boss behind the National Health Financing for Malaysia. Please welcome Dr. Rosita Halina Hussein, who is the Deputy Director for the Unit for National Health Financing under the Ministry of Health. Ladies and gentlemen, Dr. Rosita.
Thank you for the introduction. I would hardly say I'm the boss. I have many bosses above me, and Tan Sri Bakar was once my boss too. Assalamualaikum, good morning everybody. Nice to be back here, and this is my alma mater, and I used to sit, well, the hall looks very different now. I used to sit in that row, in the second row, so I was just like one of you today. But during that time, there was very little discussion on health economics and health financing, so I'm really happy that you all have the chance to get this exposure, because I think it's very important for you to understand the context within which we live and in the future you all will be practicing in. Tan Sri Bakar has set a very nice stage for me to go on with the discussion, except that we need to rush through this because we only have 7 minutes now. So let me see if I can get this right. Okay, so much of what Tan Sri Bakar said already, you will realize that Malaysia has what we call a dichotomous healthcare system. There's a public system and there's a private system. The public system is publicly funded through general taxation, etc., through mechanisms of the government to provide healthcare through public providers mainly. And the private system paid through private monies, which is out of pocket. That means individuals paying from their own pockets, or through employer as an employment benefit, or through buying private health insurance. And these mainly go to private providers. And as much as we try, it's been very difficult to merge these two dichotomous systems, and therein lies a lot of problems and a lot of inefficiencies that we could do to improve such a system. Given the fact that the private system mainly provides services to those who can afford to pay and those who can access the services, whereas the public system is geared towards delivering coverage of healthcare to everybody, so pushing towards the envelope of universal health coverage to a government tax-funded system. So when we look at that, and despite the fact that we say we have a dichotomous healthcare system, 77% of hospital admissions occur in the public sector. More than 80% of hospital bed days, because those who come to the public sector also stay longer than if they were in the private sector. So more than 80% of bed days occurs in the public sector. And 60% of outpatient visits to clinics, etc., is in the public sector. However, when you look at healthcare spending, for the volume of work between the public and private sector, the funding for the public sector is only at 53% of total health expenditure. So you can see that the public sector delivering 77% of inpatient care, 60% of outpatient care, with only 53% of funding, is a very stretched system compared to the private sector, where there's a lot more room and space to maybe bring in more services, and that's where we think of trying to bring the two sectors together. When we talk about universal health coverage, I think we have to realize that the country actually achieved universal health coverage many, many years ago. And sometimes that's where we take that for granted. We didn't realize what a big achievement that was for a country that was in the early stages of development as a low middle income country at that time. This is during the time when Tan Sri Bakar was DG and I was just coming into the system. And when we look at universal health coverage, it's not a single dimension. You look at things in the context of who's not being covered. You look at things in the context of what services are being provided. And you look in the context of, for that service provision, how much do people have to pay, whether it's out of pocket or through a more systematic way of paying. So, you know, there's nothing black and white about health policy. A lot of it is very context specific, and it's all shades of grey rather than an absolute yes or no. So with that funding that we've had from the time of independence, Malaysia really achieved a lot. And agencies like the WHO, the World Bank are in awe of our healthcare system, given the fact that we were able to achieve universal health coverage at a time when the country was not yet a fully developed country. Well, we're not yet still, we're still an upper middle income country. Our parameters of indices have come tumbling down. And Tan Sri, actually we do a lot of measurements in the public sector. Where we fail is measuring the private sector. And that's where we would like to know much more about the other half of the delivery of healthcare, the other segment, can we understand what's going on there? For the money that's going into that, are we getting the right outcomes, the right value? The other thing I think that we have to be really careful about is this, saying which system is good or which system is bad, because as Tan Sri says, it's not as simple as that. It depends on what the moral obligation of all of us as citizens of each country. What do we want from our healthcare system? It depends on the willingness of the political environment to have the discussion on that. And as much as we say the UK is a struggling system, if you look at it, they spend more on healthcare than we do. And their infant mortality rate, which is a very good indicator of the overall healthiness of the healthcare system, is much lower than Malaysia's. So as much as people say, oh, the NHS is a failing system, they still do far better than we do. Even NHS, even the US, which is truly a very difficult, very bad system because they spend so much to get so little. But even then, their infant mortality is still lower than us. So nothing is quite as clear-cut as we would like it to be. But certainly, Malaysia faces a lot of challenges. Tan Sri Bakar said about the growth of new expensive medical technology. Ladies and gentlemen, that is truly the #1 driver of healthcare costs. And, particularly in the private sector where there is an arms race, because that's the way of attracting patients. The more modern equipment, the more modern technology you have, is how patients will come to you, is what is driving the rising cost of healthcare. Coupled with the fact that we have a growing population that's going older. By the year 2020, we are an aging population. By the year 2035, we are an aged population. Coupled with the fact that our population is unhealthy, we have a double burden of disease. We have re-emerging communicable diseases, and we have a lot of non-communicable diseases. And these non-communicable diseases, almost, when we look at our population statistics, half of them are undiagnosed. Half the diabetics in this country don't even know that they are diabetics. Almost half the hypertensives don't know that they have hypertension. More than half of people with high cholesterol go around not knowing, quite oblivious that they have high cholesterol. What more, mental health, etc., cancers. So again, going back to measurements, Tan Sri, I was talking to our oncology and our cancer registry patients, and Tan Sri was talking about oncology care, cancer treatment. Actually, yes, in Malaysia, the data shows that if people are picked up at stage 1, stage 2 of cancer, our outcomes are actually very good, comparable to other countries, comparable by international standards. Our problem is that our patients only come in at stage 3, stage 4, and that's where we fail miserably because it's already very late. And a lot of them have gone through many other treatments, traditional alternative care, before they come into allopathic care. And because of all these challenges that we face, healthcare cost is rising. No matter what the Ministry of Health or the government budget will be, it will never be enough. And there is very high out-of-pocket expenditures, as Tan Sri mentioned, 38% out-of-pocket right now for Malaysia. So what is it that we're trying to achieve? Have I overshot the slide? All right. What is it that we're trying to achieve? As it turns out, there isn't that many different types of health financing. There's only really rationally about 5 different ways. But when you look at these 5 different ways, you also want to measure it in terms of equity, its inclusiveness, its fairness, because it turns out the poorest people in any country are also the sickest people, and they are the people who can least afford to pay for healthcare. So when you talk about financing, you really have to think about fairness and equity. You think about risk pooling, because nobody can save enough for their own healthcare needs. So you need to pool that risk, the financial risk of falling sick, into a bigger pool so that when you do fall ill, you can tap into that pool, that has been shared across, hopefully, the population. You think about reducing risk selection, because in certain ways of financing, they only want the healthy people to be part of that pool, because then they don't have to spend. And you talk about efficiency, not wasting the limited resources we have in healthcare, or maximizing the resources that we have. Imagine the resources that we have in the healthcare, the public healthcare providers and the private healthcare providers. Can we tap into the extra resources in the private sector to take up some of the workload in the public sector type function?
Doctor, you have 1 minute.
Really maximizing the expenditures we can. So, like I said, it's a hard sell to do this in 7 minutes. The idea is that you want to push financing much more towards not a public delivered financing, not only from government money, but a publicly managed financing system. So there's a slight difference there, because at the end of the day, all monies come from people, whether it's tax money or insurance money, etc. But who manages that money is the critical concern. So I don't have the time to go into competition. I think the main thing you need to know is it's a fallacy, it's theoretical. There's no such thing as the perfect market in any industry. And the fact that there are huge market failures in healthcare. So if you say leave it to the competition to get the greatest efficiency in healthcare, we will never achieve that, and that's one consideration that we really need to understand. And so in the context of that, what is the interest of the government in looking at healthcare financing? It's certainly not about making huge profits. In fact, every time we talk about structures of financing, we talk about a non-profit structure. The idea is to improve health of the majority of the population, to allow healthcare production to be adapted to the needs of the country, moving from just acute care to much more management of chronic diseases, ensuring equity and access to healthcare, improving quality, controlling the cost of healthcare and the sustainability of the system. Because at the end of the day, we want the rakyat, we want people, 30 million people in Malaysia, to receive good healthcare at an affordable cost, and to ensure there is efficiency of the system. Hence, I finish my talk.
Thank you, Doctor. Actually, we sort of gave a bonus of 3 minutes. It was total 10 minutes, but thank you very much for doing that. I know it is almost an impossible task to put together what is basically the national's healthcare financing system into one single presentation in whether 7 minutes, 10 minutes, even 30 minutes sometimes. Our own doctors don't really understand, our policymakers, our politicians don't understand. So with that, thank you very much, Doctor. The next speaker is coming from the private sector. She has distinguished herself very much in terms of heading a very prestigious hospital. She is the Chief Executive Officer of Thomson Hospital, Kota Damansara. I think that's the new name, right? And the Group COO of TMC Life Sciences. So without further ado, please, ladies and gentlemen, welcome Wan Nadia, Wan Muhammad Abdullah.
Okay, I'm going to use this because I'm very nervous, and so I'm going to be walking around a lot. Obviously, thank you very much for inviting me. I was very honored to be put on a panel with two very distinguished speakers, and I was wondering why on earth they would invite me to come and speak, but here we are. I'm going to speak from a private sector perspective. And so I put in a few slides about who's Thomson, because basically we just changed our name a month ago, so a lot of people asking who's Thomson. And so just to run through quickly, and this is going to be pertinent to where I'm coming from. In our group, we actually run a tertiary hospital, Thomson Hospital Kota Damansara, which used to be called Tropicana Medical Center. We also have 6 fertility centers, which are ambulatory care centers, which means we don't admit the patient. And then we have pharmacy, and we're also building a hospital in Johor, which will have, as part of it, research and education facility as well. So this is just where we are across Malaysia and the projects that I'm running right now. Okay, so then we come to the heart of the topic, which is financing, which really boils down to money. And I'm not going to sit here and pretend that I know anything much about this topic because I didn't study it in university, but I'm just going to bring out a few questions or observations that I have being in healthcare for the past 8 years. Okay, so a lot of questions come about, and it's a very political question as well, about why private healthcare is so expensive, okay? So, because public healthcare is free, and therefore when you walk into a private hospital, everything looks expensive? Is it because everyone in private healthcare is out to make money for themselves? Is it because our ringgit is so low? I do have people coming up with these kind of answers. And is it all of the above? And so I'm just going to bring up some topics here so you can ask questions later to the panelists about these topics, okay? So public versus private, I think Dr. Halina has already shared about the spending in public versus private, and it's roughly equal, but as she said, in terms of service, obviously, the public sector is serving a lot more people than the private sector. And are costs going up? So there was this study, obviously, to show the medical inflation rate in Malaysia, as you can see, 12.7, which is on the higher side, where all the developing countries are actually, the costs are running up much faster than the more developed countries. Okay, but on the other hand, can't really say that we're that expensive either, because we have people who are coming here for healthcare because they think it's cheap from other parts of the world. So, you know, where do we actually stand? Are we really that expensive? And Dr. Halina also talked about group risk pooling, which is basically insurance in a group of people. Only, you know, there's probability of only a fraction of you who are falling sick and actually need to spend money on healthcare. And I also want to talk about maximizing individual segments, which is about, is everyone out there really out there just to make money for themselves, okay? So this is roughly my very simple view of the healthcare delivery system. You have the preventive care, primary care, secondary care, tertiary quaternary care, and end-of-life care, okay? And the cost kind of increases as the complexity increases, right? But in terms of ROI, in terms of the effectiveness of the cost, it decreases as we go down. As Tan Sri Bakar mentioned, you spend most of the money in that last 1 year of your life. And I went to school at London School of Hygiene, and to get to class every day, I used to walk through the British Museum, and there's an exhibit there, if you've ever been, of the number of pills a person consumes in a lifetime. And there's this very long corridor where the pills are, and most of those pills are actually consumed in the last year of life. And so it's really hammered into you about the cost versus sort of ROI that you're getting back for every dollar that you spend. Now, in Malaysia, people are operating basically in silos. And okay, you have people in the private sector and the public sector who are playing in these parts. You may have hospitals, ambulatory care centers, tertiary hospitals, obviously, or hospice and aged care. In primary care, you have GPs, or in certain countries, you have nurse practitioners. Now, the nursing, I think, in Malaysia hasn't actually gone up to that level where we have nurse practitioners who are taking over some of the load of the GPs. I went to school in Boston, Massachusetts. Is sort of a very different model from the rest of the US, where they have sort of universal insurance, and a lot of the care there is now being taken up by nurse practitioners who are step up from between nurses and GPs, basically. And then you have the lifestyle and wellness centers that are coming up in terms of preventive care. Now, I colored these boxes differently because regulation-wise and political-wise, there's a reason why somebody can't play in all of these areas. Okay, so in Malaysia, if you own a hospital, you can't own a GP network by law. And so what happens is that you are basically having silos, And obviously, although there's no perfect competition, people would want to maximize how much they make in each individual piece. And so I think that is something that we all need to consider, because as Tan Sri said, a lot of it is driven by politics. There are various reasons why people want to maintain these silos, but is it necessarily the best way to actually have a healthcare system? Because we know that this part is actually very important in order to provide sustainable care. But the big players can never play in this. So this part is actually really fragmented. So, and then we go to the third part, which is about the ringgit. I'm going really fast here because I know then Azrul will tell me I've only got 30 seconds left. So apologies. So is what you see really what you get, okay? So a lot of people look at the cost of healthcare and they think, okay, there's doctors' charges, equipment charges, beds, drugs, diagnostics, the whole lot. And then there are all the other things that comes with providing healthcare that we can't charge or can't collect money for. ICT systems, infection control, safety, healthcare, premium, because if you put the word medical in front of something, it suddenly doubles or triples in cost. Training and upskilling of staff, billing and administration, regulatory and compliance. And a lot of doctors actually don't understand this when they want to go into looking at administration. So I had a doctor told me, like, why are you charging for everything? You know, why is everything so expensive? Like, it's a good thing you're not charging me for oxygen. And then I looked at him and I said, doctor, do you know how much the HEPA filters cost? You're lucky I'm not charging you for the oxygen. And so, you know, there's that awareness of where the cost is coming from. There are a lot of hidden things that are submerged that actually the patients or the end consumers don't see that you need to invest in and maintain. And, well, a lot of it is imported. And so say what you might about trade wars, macroeconomics, the ringgit, the fact is all of those external factors will actually influence the amount of money that we need to provide care. And really my personal beef is when we talk about reforming the healthcare system, we also need to talk about trying to develop local players in these areas, because this is where significant costs come in. So for example, ICT systems, if you look at HIS, a hospital information system right now, there is no local player to provide this system to the private hospitals. But the government hospitals have been on EMR for the past 10 years. So they've gone on and done it, but we have somehow not able to develop the ecosystem to encourage entrepreneurs to develop local EMR systems for the private hospitals. And so I still have to churn out in US dollars to purchase a system from the US or any other country. It's still imported, even though our public hospitals have been running EMR systems for the past 10 years. So this disconnect actually, I think, is something that we need to look into, because if you want to look at financing costs as a whole, this is my last slide, we need to look at all the other drivers and try to encourage innovation, development in all these different areas. Even in equipment, recently I was at a trade fair. Now an MRI, as you know, costs in the millions, 3-4 million in the minimum. And now there are these Chinese equipment manufacturers. They're coming up with equipment, CT scans for 400,000 ringgit for a one, I can't remember how many slices it was, but it was quite low. And you know, the Chinese are just going to come in and drive all of these German Siemens, Philips and all out, but they're doing something to actually drive the cost, and I believe the government's also helped asking them to look into this, because it will have an impact on the cost of healthcare delivery. So that's it. Thank you very much for coming on a Saturday to come and listen to all of us talk, and yeah, look forward to all your questions. Thank you.
Thank you, Nadia. So we'll just come back on stage and take your questions, and to moderate the next part of this morning's forum. So one of the things that that is very clear, and especially I think Nadia put it very nicely in terms of where does the money go to, especially from looking at it from the costs of healthcare itself. It's too easy to look at these issues as very abstract and being something of a macro picture where you don't see where the money is going to. And to put it in that perspective is quite well done, because very often Malaysians, when we look at the cost of healthcare, especially when we look at public healthcare, we see 1 ringgit, we see 5 ringgit, and somehow or another that's the cost of healthcare, and that's the layperson. Because they don't see that there is money that actually goes towards paying doctors, paying for the equipment, paying for the syringes, solutions, etc. Every single thing costs money. So at the end of the day, we need to find a way to fund it, and most importantly, ensure that people are compensated for the work they do at the same time. It's almost an impossible mission. But it's interesting to note though, Malaysia, Nadia's slide indicated where Malaysia is in terms of medical inflation. Now, your slide put last year at 12 point something %, and that was the case for last year. This year, for your information, it's projected to be 17%, 17%, which is few notches higher. In fact, it's an entire country for some of those countries that you see there in terms of the increase. When you consider the inflation rate being 4%, we have a serious problem. Now, the issue here is where is the money going to? Where are the spiraling costs with regards to this? Where is this 17%? Dr. Rosita, what do you think?
I think you've seen it already on the slides. It is the fact that the 70% is very much driven by, one, the medical technology. And when I talk about medical technology here, I don't just mean the drugs and the actual delivery of healthcare, but inclusive of the IT, the manpower, etc. So the audience, you also have to broaden your mind in terms of what does technology mean. It doesn't mean just the machines. Technology includes IT, technology includes systems and processes. If you shift from one modality of delivery to a much more expensive modality of delivery, that spikes up. And because the concern is there is an arms race to push much more technical medical technology, the public sector feels the backlash. Because when the private sector provides some new modality, the question that comes to the public side is, why isn't MOH, why isn't the government providing that same technology? We want it in the government, even if we don't see it as being cost effective or cost efficient.
But doctor, isn't improving the quality of healthcare something that we should aspire and strive for? I mean, why is that a bad thing that
Absolutely,
but
that's where we have systems called a health technology assessment, because you need to have data, you need to have the proper analysis to drive and to advise policymakers, advise managers of healthcare on what works and what doesn't.
Okay, thank you, doctor. Just a minute. We've been talking about recently increasing the allocation as per the GDP. We're talking about increasing percentage points. In fact, that one was a political promise by the current government. Tan Sri, is there a magic percentage that somehow or another all of our woes concerning healthcare financing has been resolved? I mean, we've heard 6%, I think, is the promise. Is there an actual percentage that we should be really looking at? Which is where we should be?
Okay, first, healthcare is expensive. Okay? When we did a study in 1992, long time ago, about comparing primary care in a General Hospital, Penang, and the GP, we found that the public sector is more expensive than the GP. So don't be fooled because the politicians say public sector is cheap. The amount you pay is cheap, but the amount the government to pay is very high. Okay, now what percentage should we pay? I think when I was in service, when I was doing all the studies on health financing in 1987, 85 to 87, we were spending less than 2% of GDP on health. And the target, as recommended by the WHO, was 5%. Now they're recommending 8%. Actually, we got to decide how much can we afford, how much do we want to spend. I think to aim, because now we have a 4.5, 4.6, to aim at 6%, 7% is reasonable. So the issue is we must spend more. But we must reduce the cost. And I'm talking about total cost. Okay. I feel that Dr. Rosita here and the Minister of Health should accept the triple aim of IHI, which now in America is trying to push and other countries are trying to follow. The three aims are this. One, increase access, increase the experience of care that results in second aim to improve the outcome of patients to an extent that it improves the health status of the community. The second aim. And the third aim, while doing all this, we must continue to reduce the cost. Okay, let me just tell you
Very
something.
quickly.
In Japan, you go for a CT scan. 8 years ago, it cost $98 US. In the US, it cost $1,200. Why? The same medicine as a pill in the US is $1.50. In Japan, it's 25 cents. Why? It's mandated by the government. It's mandated by the government also that the doctors can pay only this much, hospitals can spend only this much. So they squeeze doctors, they squeeze hospitals.
So, Tan Sri, you're promoting a price control? Is that what you're saying?
Okay.
Very quickly, Tan Sri, I just want to say yes or no.
Go ahead.
Good, okay.
Yeah.
Nadia, you know, private sector healthcare has been painted as the bad guys of Malaysian healthcare. In fact, if you look at the ranking of CEOs under the Edge, I think 2 weeks ago, the top 5, I think a few of them were
What
CEOs
wasn't
of
our group, it was IHH.
had really high, percentage of payment to the CEO. So people look at that and wonder, am I paying for these people to get rich?
I think it's an anomaly. I think IHH aside, definitely healthcare is not a business to go in to make easy money. It is not easy at all. But I think there's a lot of private investment in healthcare because it is a very consistent business. So you make 2%, but you will make 2% every year for foreseeable future because people will always fall sick. And that is the attraction for private investment. But coming back to drivers of cost, all of you here are voting or future voters, and you need to consider actually when the government says something, exactly what is it that is going to impact. So for example, cost of healthcare inflation. When they introduced the GST, they said that healthcare was exempt. But what that meant was that I couldn't claim back my input costs. And therefore, when you have a tax that isn't transparent, what happens is people increase the prices just to make sure that they have buffer. And so that actually led, I think, to a significant jump in healthcare costs, especially in the private sector, because the government was exempt. That had follow-on effects, because once you increase the price, nobody is going to reduce it. So say what you like, when you change the tax regime, prices go up. Even if they reduce the tax later, the price will remain.
Exactly.
So that's one. Secondly is that we already have, in a way, price controls. As you know, in the private sector, there is this thing called the fee schedule that doctors have to follow in terms of ceiling prices for their services. And there is now talk about capping also the hospital portion, which is basically driven by regulators like Bank Negara, who actually never really went into healthcare and tried to understand actually what is it that is driving the cost. So then there's this danger of people wanting to regulate but not really understanding the industry in the first place. But coming back to politics, I just had
Very quickly, Nadia.
meetings with insurance companies. And recently, the MMA had a memo that said that doctors who have an arrangement with insurance companies by discounting their fees and charging less are going to be liable for fee splitting. And so what happened was that all the doctors in the private sector who previously would say, okay, AIA, you have a big group of patients, I'd be willing to give you 5% off my fees, are now legally not allowed to do so. And so overnight, then the bill goes up by 10%. So
Literally overnight.
Yeah, literally overnight. So there's a lot of things that are coming into play that are sometimes within or outside of our control, but it does have a very visible impact on the cost of providing care.
Thank you, Nadia. We'll take a couple of questions. Please very quickly make your way to the microphones there. Don't be terrified, you're not going to be charged for any question that you're going to be asked, don't worry. No questions concerning healthcare financing? Or you're intimidated? Yes, sir.
I might give that man a round of applause,
Please,
please.
please.
Testing 1, 2, 3. All right. Actually, I'm participating in research which is going to which is dealing with the research department, which is dealing with the records department in a hospital. And I'm wondering, like, is the cost of managing the patient's file and buying a property just to put patient's file significant for the hospital's advantage? For example, like our patient's record, we always write it down and we don't put it in like a system or server, we call it, like those overseas countries does it. Is the cost of doing so much more expensive than buying stationery and also property for that?
Is your question aimed at Nadia or someone else?
I'm not sure, sorry.
Oh, you gotta be sure, man.
For
Okay, then.
Nadia.
Okay, I'm not a doctor, so I put that straight. I would have been maybe if fate had intervened. Okay, so paper is definitely cheaper than the IT, and the reason is because, as I said, the systems are imported. So on average, a hospital would need to spend a minimum of 10 to 16 million for a new IT system with EMR. Secondly, there are now issues about cybersecurity, as you have all read. Mr. Lee Hsien Loong's data was hacked, and so now the requirements to safeguard your data, the questions around cloud storage have now come into play, and that also drives the cost up. And thirdly, because when you move to a fully electronic system, the processes in a hospital need to change as well. The type of hardware you provide, the way doctors prescribe the medication, which, by the way, that is also a key challenge, is convincing the consultants to move away from paper. They seem to be happy doing it in public, but when they come out to private, suddenly it's like, no, you can't do it. Yeah. So I think that there are a lot of hidden costs, and just aside from the direct costs of buying and implementing the system.
Can I just ask, did you want to answer, Dr. Isabel? Please, go ahead.
Well, I think I thought I'd jump in here because I think there are a few things that, yes, ICT systems are expensive, but in the long run, the return on investing on ICT systems are much greater, not just in terms of the pricing of where you store your storage and all that, but the portability of that information, the ability to analyze that information to see what the outcomes of treatment, etc. So there is a lot of value for that, number one. Number two, I'm a little bit surprised when Nadia says there's no local vendor, because the Ministry of Health doesn't develop all the ICTs ourselves. We actually use local vendors to develop the system, etc. So they are out there. I don't know why the private hospitals don't look into that, but they are there. And the third thing is, you see this rising cost of healthcare and how it transfers to the public, to the patient. There is a statement which Cik Nadia said, the profit is always at 2%. So the thing is, in the mindset of the private sector, and I dispute that 2%, for private health insurance, for every ringgit that some of you might have private health insurance in your family, for every ringgit that you're paying on premium, only 60 cents goes to healthcare. Exactly. 20 cents goes to profit, and 20 cents goes to administration. And that's where we see the market failures of private health insurance and the inefficiencies of health insurance, and that because there's so much market failure, the suppliers can and do induce demand so that they can maintain whatever profit margin they want to make. So regardless of the cost going up, their profits don't come down. Yeah. They just transfer the cost over to the patient. So that's where we need to look at things like that.
Well, thank you. The next question will be for Tan Sri. And before I ask him and put him on the spot, how many of you have insurance? Put up your hand. How many of you have life insurance? How many of you have health insurance? How many of you have insurance but you have no idea of what on earth you have? That's the reality. A lot of you better check up on your policy, because a lot of people don't know exactly what's in the policy, and most importantly, what is covered. And then when you end up going to the hospital and you suddenly realize that, oh, sorry, you're not covered. Oh, sorry, this is the life insurance, not your health medical insurance. So let me ask you, Tan Sri, we heard this morning from Tan Sri Ismail Marikan, and I'm sorry if this puts you on the spot because he was your successor after you. He brought up the issue of having compulsory national health insurance. And the Galen Center for Health and Social Policy is of the position that we support the idea of a compulsory national health insurance for the reasons that Dr. Rizita has presented today concerning the pooling of funding and pooling of risk. So can I ask you, Tan Sri, your own opinion concerning whether it should be voluntary or compulsory, or whether the current system is adequate as it is? We don't need another insurance that people now have to pay for or have no idea that they're paying for. Go ahead, Tan Sri.
Okay, I think what we do need is a prepaid system. Whatever system it is, it must be prepaid for you, so that you and your family, should you need health care, you don't have to worry about it. Okay, to my mind, that is a moral issue. And we must tell our political leaders this is what it is. So when I was in government, we made the recommendation, and the recommendation was to create a health fund in which the government will contribute for the civil servant, for the unemployed, for the elderly, and people are working and the employers contribute. So that was the but to me, the decision is we should have a prepaid system. So one way is to have an insurance system. Now, as I pointed out, if you have private insurance, it is risk rated. In other words, you've got an illness, you've got high risk, they exclude you. Like for me, I'm over 70 years old. I cannot get insurance. Okay? So we don't want that. Whereas the not-for-profit insurance system, they collect money and they pay for everybody's healthcare need, no questions asked. Okay, so whether you have it through the budget or through a health fund, doesn't matter. Private insurance can be on top of that. In other words,
so you don't need to let go of your private insurance.
You don't have to. It pays for the co-payment, you want a better environment, you want a better choice of doctor or hospital, that's fine.
Could I ask Tan Sri a question then? What about
Very
the
quickly.
model where, I'm quite admired of the model where Kaiser has it in the US, where they have the insurance and they're also the provider, so they have visibility across the chain. Would that be something that would be possible